Thank you for that introduction. I've been involved in the crisis lines for quite a while, so that's where I get the link to Lifeline International, which is a network of 30 organisations in 25 countries. But I also do a couple of things in Australia, including chair an advisory group to the National Suicide Prevention Office. So it's more from, I guess, the Australian perspective I'm speaking this morning. Okay. Oh, I see it's already gone ahead. So I think I used the phrase, that I would talk about a national suicide prevention strategy in a sunburnt country of wide open plains, which is a bit of a point to some of the ways people sometimes understand Australia. Australia actually was leading the world in suicide prevention strategies way back in the 1990s and introduced a youth suicide prevention strategy at that time and achieved a reduction in suicides by younger people. Since the 1990s, we have done a number of things on suicide prevention, and per capita we have probably more suicide prevention researchers than any other country in the world. But we also have some innovative programs. We have done a lot of work on frameworks and guides, and a lot of very, very useful initiatives that have developed into lasting programs, including very strong crisis lines. However, the suicide rate in Australia has not reduced in the last decade, and a number of years ago this reality was drawing some very real rethinking, both of people working within suicide prevention, but also from governments who are starting to say, well, what's going on? So there was a request for advice to the Prime Minister on what might be more effective in suicide prevention. And a lot of work was put into the preparation of that advice, and it included a whole range of things, but a couple of very key things. The first is that it recommended the creation of a national suicide prevention strategy. I know that sounds a little bit weird for a country that in the 1990s managed to have a youth suicide prevention strategy, but we had not actually made the move into a whole of population strategy. We had frameworks, we had policies, we had 5-year rolling plans with states and territories, but we did not have a strategy in the sense of pinpointing the things the country needed to do as a priority to reduce suicide and to create a mix between the long-term and the immediate. The second thing the advice said is that it needs to be across all of government, that it's not just about health, it's about health plus all the other agencies. And there's a very good example of why this might be important in Australia, because we are coming to the conclusion of a Royal Commission into deaths by suicide amongst defence serving personnel and veterans. And that's certainly honed some of the minds of those within government and the wider community. And when you start to look at the reasons why people in defence and veterans die by suicide, it's not just about mental health issues. The third thing that the advice suggested that I wanted to note today is an attention to coordinated data. And again, for a country like Australia, which actually has very large amounts of data, the issue wasn't so much about the data supply, although that's one of the things we're working on, but the data coordination and the ability to look at data coordination in a way that tells you things that you can learn and apply into policy. So that, that's another aspect of what's been addressed. So where are we now? Well, I wish I could say to you, here is our National Suicide Prevention Strategy, but I cannot at this point in time because the draft strategy is still under development and ready for formal consultation in the community, and we're hoping that might progress in the coming weeks. But I can give you an insight into where the work has landed and what's going to go forward, and we expect we'll receive very good support. So the first thing about the strategy that you can see from the diagram is that there are two key components, one called prevention and the other one called support. So what's different about this strategy from anything else that's been done in the past? It's the stuff in the yellow box. Most of what has been done in the Australian approach to suicide prevention, at least nationally, has been in the support side. That is, we've invested in services to support people who are in suicidal crisis. We've invested in services to take pathway of care through. We have looked at postvention and aftermath aftercare services. So all that's been on the support side, and that's very good and it's very important, but we have not been doing a lot on the prevention side. The prevention side, and we've got the particular phrase there around suicidal distress. So I guess that's the way that we're conceptualising things, that is, let's see if we can find out what it is that might prompt suicidal thoughts and movement of those thoughts into plans and intentions and behaviours. And the whole notion of distress, in other words, what are the things that happen to people in their lives, including some of the elevation of symptoms that might suggest the onset of mental ill health, but also things like what's happening around income security, what's happening around family and domestic violence experiences, what's happening about early childhood adverse experiences. We've recently had a study in Australia that has shown 2/3 of the adult population in Australia has experienced some form of maltreatment as a young child. That's an incredible finding with very significant implications around policy and, of course, suicide prevention. But also things like alcohol and drug use, particularly alcohol. Things to do with what sort of income support is provided for people who are experiencing trouble securing employment or can't work for other reasons. These are, if you like, the macro factors in suicide prevention. These are the things that actually turn the whole ship around in terms of a prevention orientation. So that's why this strategy has two components. All right, go into a little bit more detail with it. So where does zero suicide healthcare fit into all of this? Well, you might recall from the presentation Sue Murray gave yesterday that we are advancing zero suicide healthcare in most states and territories now. So those are where the health systems are predominant, and we've had, I think, a very pleasing pickup of zero suicide across the country in various times and at various stages. So everything from quite mature development through to people who are just embarking on the journey. But this aspect around the prevention of suicidal distress is more about what's going to happen outside of some of those healthcare systems, or perhaps a greater orientation to the contribution that primary healthcare can play. And for zero suicide healthcare, this becomes really critical because we're trying to prevent the entry into the emergency departments, the entry into more intensive or acute and specialist services, by seeing if we can provide healthcare earlier. So there's a connection there to zero suicide healthcare because those are the sort of pathways that we'd want to encourage occur. And maybe there will be people who move into more acute services, but if we can provide services and support much earlier and address the issues that are generating some distress, then we'll be more effective in our prevention. So that's where some of the relation of the first bit. But it would be fair to say that, Am I going the right way? Yep. That it's in the second area of support that you'll see much more explicit mention of issues around the healthcare systems and particularly the initiatives in zero suicide. So there we're looking at system-wide coordination as the term we've used, which is a point to the incredible fragmentation that we experience in Australia across health. So we have health being provided by all levels of government, with the states being the predominant role, but the Commonwealth also being very, very prominent in primary health care. We also have the intersections with the related services such as alcohol and drug and other social services, and system-level coordination is a huge challenge. I think mentioned yesterday some of the things around people falling through the gaps and so on. Well, that's a very real issue in our country. But also to have more consistent pathways, so we know what care is going to be provided, to look at how we can have dedicated care coordination, which is more around actually coordination focused on the needs of the person rather than what can be provided, and some collaboration across services. So that's the way the strategy is working. I'll just go back to the first slide. I wanted to make a couple of other points. And maybe it would be interesting to start by just a couple of, interesting or fast facts about Australia that you may not know. I think most of you know that Australia is located in the southern hemisphere and it's a long way from here. Long way. You might also know that it's the home of the oldest living culture and civilisation in the world, our First Nations peoples. which are actually more than 200 to 400 discrete groupings within First Nations across the country. What also you may not know is that relatively small populations, somewhere around 25, 26 million, and about 1 million of those are living outside of Australia at any point in time. What you may not know is that around one in 4 people in that population was born out of Australia, and 1 in 2 of that population have a parent born out of Australia. So we were very much a migrating population overall. The sort of imagery about the sunburnt country and the wide open plains is all very nice. Yes, we are a big continent. We have a lot of space, if you like, or a lot of land mass, and there are some aspects of that land mass that are literally very wide open plains. Most of our mountains have been eroded through the natural processes millions of years ago, so we don't have many high mountains. But what often comes to terms with the imagery is, Australia, the sort of, the bush Australian and all the outdoor stuff and so on. Let me just maybe correct the thing there. Actually, 3/4 of the population live in 3 large cities, and another quarter don't. So I'm one of the 1/4. I'm a bit of a odd one out in the national population. I don't live in a large city. I live in a rural area on the coast. But you think about it, most of it is very urbanised. So everything that's about service provision and health systems and policies and so on is trying to deal with this conundrum that actually most of it's happening in urban environments with all the stuff that means. And then there's this 1/4 that's not in an urban environment. And somehow the system's supposed to adapt and change to those. And it doesn't always work. It's very easy to talk about the supply of mental health professionals in the urban environment and referrals to services. Once you get, even 100k out of Sydney, in my case, 130, 150k down the coast, there is not a free supply of psychiatrists or even psychologists, let alone even mental health nurses. And if you try to recruit into a town of 10,000 people in a rural area, it's going to be very difficult. There are different ways in which things need to operate. So that's some of the reality about Australia. Why does this matter for zero suicide healthcare? Because it means that we've needed to look at not only what happens nationally, we've needed to look not only at what happens in the statewide systems and state planning, but we need to look at the regions, fairly local, and try and push it down as much to that to see if we can get better operation of the healthcare systems. So when we talk about that thing around coordination of the system in the strategy, or draft strategy, is very much looking at what's going to happen at the regional level. This is, I guess, part of the other reality test always that we're looking at. The other thing I thought I'd just mention in closing is the thing about data, which I touched on, because that's also very relevant to zero suicide. One of the initiatives out of the provision of advice to government has been the funding of a data coordination project nationally, and that's occurring through the Australian Institute of Health and Welfare. If you like statistics, and who doesn't, I love a good spreadsheet. Then you can Google the Australian Institute of Health and Welfare website, Google suicide prevention data, and you'll come to the head page through which you can access a whole pile of statistics and graphs and data relating to suicide and suicidal behaviour. Now, literally 5 years ago, that was not possible across our country because of the difficulties of bringing the data together. Most of the data is held by states and territories, some of it's even lower down in the regions, to bring forward things and have a picture of not only the deaths by suicide, but also behaviours, plus some of the social and economic determinants around suicidal behaviour and distress is a major innovation, and we're quite proud of where that's taken us. So, go have a look at the website, and I hope you enjoy it. But what it also has done is suddenly release a whole lot of new insights, including commissioned research that the Suicide Prevention Office has been able to fund and support to analyse what does it all mean. When I make the point about the child maltreatment survey results, which are an independent exercise, what we'll be able to do is also now have a look at how that matches across geographic areas of disadvantage in Australia and start to figure out what might need to occur regionally in terms of programs and supports and services for families. One of the other things that it's drawn is the incredible relationship between alcohol and suicidal behaviour. You know what I mean? Maybe in Australia we didn't need data to tell us, but we certainly need data to advance the policy and the change. Some of the other things around the provision of income support, where that has been good and effective, that has reduced suicidal behaviour. But we had this occurrence in Australia recently, which is called the robo-debt matter, where the Commonwealth Government, which provides income support through a social security system, decided to launch into taking money back from people who are receiving income support where they perceived that they hadn't been accurate in their portrayals of other casual and related income. So, if you're on income support and you receive some casual income, you're supposed to declare that, so it might mean an adjustment to your payment. But they did that through automated letters based on algorithms to try and identify people who had apparently not disclosed other casual income. The result of that was that thousands of letters went out to a lot of people who are the very poorest people in our country, and many of those had enormous distress as a result of that. They had their payments cut off, which heightened their distress. They had to try and take action to clear the debt or to appeal through a very complicated appeals process. And as a result of the Royal Commission that was conducted on that, some of them died by suicide. So if you want to look at things like social determinants of suicide, it's probably one of the best case studies around, very tragically. And again, you can Google robo-debt inquiry and you can read the results of that, thankfully, to the Royal Commission's work. So, I think the issue about data, though, is showing us exactly things like that. So hopefully in Australia we will never again have a government policy which looks at automated debt recovery off income support recipients, because the data has shown just how catastrophic that can be. I think for zero suicide healthcare, zero suicide reforms create a data contribution into the system. And this is very useful for the work that we're doing in improving quality of care, efficacy of care in zero suicide environments. But it also is generating data that can be used more widely. So when you look at knowing how many people are coming through a healthcare system regionally who are receiving a pathway to care on suicide-related care, that is incredibly useful to know regionally as well as nationally. When you're able to look at, well, what happened as a result of the pathway to care? Did people progress right through it or did they discontinue? That's also very useful. And of course, to look at things like outcomes. Did people, as a result of quality of care, actually become less suicidal? Did they reattempt suicide in the future? Did they indicate a process of recovery? Did they engage with aftercare and recovery-based support services? All these things are incredibly important, and data can track and measure this. And in this sense, the zero suicide healthcare stuff is contributing, I think you can see, to our strategy in our country in all different ways. Thanks.